Hey, Antonio, how are you?
Hey Aaron, how are you?
Hey, I'm good. Sorry, let
Uh,
me get this set up here.
yeah, awesome. I invited all our fellows because we had a pretty cool ultrasound case we talked about today. So
Oh,
hopefully,
okay, cool.
Henry sent me a text message. He's gonna try to join, but I think he's on vacation and his internet connection's a little bit spotty.
Ah, okay, no worries.
I will do my best to facilitate and introduce.
No worries. All good. What was the lung case?
It was pretty wild. It was a
Uh,
17-year-old who presented with about a month of abdominal pain and chest pain
yeah,
and left upper quadrant pain and
okay.
showed vital signs and essentially a normal EKG. And they did an X-ray as part of the chest pain, and she had a lesion in the left lower lobe,
Uh-huh.
which was then evaluated by point of care. And honestly, it looked just like one of like a not quite a hepaticized uh, lung tissue abnormality with a pleural effusion right next to it.
Hmm.
And to make a long story short, it ended up being a pulmonary infarct.
Huh.
What I would have interpreted as a pneumonia in like the right clinical setting.
Yeah, right.
It wasn't the right clinical setting. She'd been afebrile and
Yeah.
D dimer was elevated.
Huh.
Anyways, I'm happy to share and show you the clips, but it was pretty cool.
Yeah, interesting. And what was her history? She was a, did you say it was a sickler? No, not
Not
complete help.
even. I mean, she was on OCPs,
Oh,
and
okay.
I think she's getting a hypercoagulable workup, but
Oh, wow.
any
Okay.
family history.
Yeah.
So, and then in this particular case, I don't think COVID particularly was playing a prominent role,
Okay.
um, acute or like a MISCI or a delayed type COVID presentation. So everybody was pretty um, befuddled, I would say, with the eventual diagnosis. But her CTA was impressive. She had filling defects on both sides, and
Yeah.
the lesion, ended up. We believe the lesion because didn't have a radiology ultrasound, so we're just going by point of care. We
Yeah.
believe what the infarct because it correlates on a CAT scan.
Yeah. Hey, can you see my PowerPoint? I'm trying to share it, but I'm not sure if it's
Yep.
working.
I can see you and the PowerPoint. Yeah, June
And
20.
PowerPoint. Okay, let's see if I advance. Let's
Looking
see if I can play some video. All right.
it's looking
You don't
good.
need to see me, but as long as you can see the PowerPoint.
It's looking good. I'll keep an eye out for the chats,
All
the
right, sounds good. That'd be great. Yeah, that'd be great. Thank you.
peanut gallery.
Yeah. Who's your you guys have a fellow this coming year?
Rahul Shah, he did his pediatric residency with us and
Okay.
did fellowship with Henry at CCMC. So we're lucky to get him back.
Okay.
Exciting.
That's awesome. And how many faculty do you have now?
So myself, Lay, and Julie for ultrasound. So
Okay.
I think we're in a pretty sweet spot.
Yeah, that's awesome. How's Paul doing? I haven't talked to him in a long time.
Good. I mean, he's very involved with the pediatric residency and
Yeah, right.
associate directors for their program. And he's brilliant as always and doing multi-center stuff and
Yeah.
and, um, um, uh, fever workups in newborns and infants, and that's some of he's
His
a big
research work.
project with that too. Yeah, so
Yeah.
he's doing great. I just saw him the other day.
Hmm.
I'll let him know you said
Yeah,
hi.
for sure. And Lay too, if he's not coming, I don't know. I haven't talked to him in a while either.
He may join. I don't know. He just got promoted today.
Did he really? That's amazing. Full professor, right?
Full.
Time flies when you're having fun. Is yours coming up soon too, or
Mm-mm.
no?
No, I'm early mid career. I just got went to associate not too
Oh
long.
shit. Okay.
Long runway.
Yeah.
You must be coming up potentially.
Yeah, I submitted the paperwork. I submitted the paperwork, and then it apparently takes like a year and a half. So I'll find out, I think, next year. We'll see.
A shoo-in. It's a shoo-in.
I don't know about that, but yeah. Like, I don't know that it really affects too much, but it's nice. There's a lot of paperwork. And then I guess I'll let you tell me when to start.
Yeah, Henry usually says we'll wait 5 minutes for people to,
Okay.
the stragglers to log in. So there's
Yeah,
7 participants. Let's give it a couple more minutes, and
yeah, sure.
I'll give you an introduction, and we'll get going. Could you send us meeting link?
Have your volumes been pretty bad? We've
They're
been,
up. They're
yeah,
definitely up. They're
yeah.
they're. It's like we're in winter season in June. We're seeing so much asthma and bronchiolitis and all this stuff. It's wild.
Yeah. Yes, it's
The
fascinating.
inpatient's full. Like we're tight on beds, and it's kind of we're
So
juggling
I guess it's everywhere.
the baseball game. Yeah.
Yeah. Are you guys testing for RSV? I had one that came from an outside hospital that was positive for RSV.
Not routinely, but we've had RSV.
Yeah.
The only thing we've been able to avoid has been influenza. Still not,
Right.
not
I haven't seen that. Be fun when that hits. Although I'm not sure how's your nursing staff. Ours I guess not to talk too much shop, but it's we've had a lot of senior nurses leave.
Yeah, I think the turnover um, for Pam is always has peaks and valleys, but it does seem to be a constant challenge for the group. Um,
Yeah.
I would say we've had more sort of maybe younger mid, find opportunities there. They're a little bit more palatable. And
Yeah.
the senior core that's been there for like longer than I've,
Mhm.
14 years, longer than me,
Mhm.
they're still sort of, closing out their careers, I think,
Okay.
in the department, but we're still having issues with turnover for sure.
Mhm. Yeah.
The challenges of shift work that's arduous. It's
Yeah.
not easy. Um, all right, so let's see. Are we at 105? 105. All right.
Mhm.
So for those PPEC veterans, Henry is out today, so I'm going to pinch hit for him for this presentation. We're lucky enough to be joined by Aaron Chen, Associate Professor of Clinical Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Director of Emergency Ultrasound there. He really needs no introduction, and he's going to talk to us about ultrasonography for pediatric pneumonia. Does size really matter?
Thanks, and thanks for joining in late June. So in full disclosure, this is a talk. There's a version of a talk I gave at AIUM about a month or so ago. So apologies to anyone that already heard this, but I wanted to bring this up as a way to talk about POCUS and some of the maybe the controversies around the use of POCUS for diagnosis of pneumonia, and then hopefully talk about some of the terms that we use and maybe the way I understand these terms. I still think some of them we use inconsistently, and I think hopefully some of you will have maybe some input on that, and then maybe some future directions and areas of study. So I'm going to start with this case. This is a 19-month-old with a history of asthma who comes in with cough and wheezing fever. And this is probably like everyone's ER right now. We're seeing a lot of I think RSV and viral things that we hadn't been seeing in, even a few months ago. So, but you get a you're concerned about pneumonia, so you get a chest X-ray, and you get something that looks like this. And this is a term that a lot of our NPs had used when I started coming to CHOP. I'd never heard it before, but they call it asthmolitis, which kind of gets at that bronchiolitis, viral pneumonia / asthma exacerbation, and some people call it asthmolitis onia to throw in like pneumonia in the mix. And it's hard, right? Like you even just looking at this X-ray, it probably looked like the kid looks snotty, congested. There's noises in the lungs. Do you hear crackles, or is it wheezes or rhonchi or what? And there's a lot of schmutz everywhere. You can make an argument that maybe this right here is pneumonia in the right middle lobe or the left lower lobe, and then you get a read, of course, that is like this. So opacities that can represent atelectasis or pneumonia. Clinical correlation required. So can we do better than just using a chest X-ray? I think that's where lung ultrasound has some potential role. I did want to take maybe a step back and just say that I think as much as we think pneumonia is an easy diagnosis, I would argue that it's actually a little bit challenging. So if you look at the definitions of pneumonia, and when we say pneumonia, I think most of us probably are thinking of like a bacterial pneumonia that needs antibiotics, right? That needs treatment. That's really what we care about. And if you look at pneumonia definitions, it's actually hard, right? Like if you look at Wikipedia, they say it's an inflammatory condition of the lung, primarily affecting small airway sacs or the alveoli. And that's kind of, you go back to med school, that's like, pus in the alveoli, that's sound like pneumonia, that makes sense. If you look at the WHO criteria, they have to be a little bit more, I guess, broad, but they define it as cough, difficulty breathing, and an elevated respiratory rate. So this is pretty much anyone with asthma who just ran a mile, right? You could say has pneumonia, right? And then the British Thoracic Society says signs and symptoms of pneumonia, right? But fever, cough, respiratory symptoms in a previously healthy child. And for this one, the interesting thing is they don't require a chest X-ray. Whereas there was a review article in New England Journal of Medicine in 2002 where they were defining pneumonia, and they called it a presence of fever, acute respiratory symptoms, or both, plus evidence of parenchymal infiltrates on chest X-ray. So in this one, you actually require a chest X-ray to diagnose pneumonia, and we'll talk a little bit about chest X-rays and the limitations a little bit later. And then to complicate this even is that even though we talk about pneumonia, where most of us are probably thinking about bacterial pneumonia, there actually is lots of different causes of pneumonia, including viral causes of pneumonia, right? And even maybe fungal pneumonia. And when you look at what do we use to diagnose it, I think most of us will use a chest X-ray as as an initial screening tool. CT certainly can be a tool, but it's there's limitations obviously with getting CTs. And then can we use ultrasounds? I think that's part of the point of this talk. And then if you try to actually identify the organism, say, is this truly pneumonia, and try to get an organism, all the things that we do to look at it are tough. We send RRPs. Not infrequently, they're costly, but they can also be misleading, right? We've seen kids that have foreign bodies that have an RRP that has RSV or something, and clearly that's not the cause of their symptoms. So it can be true and unrelated. And then even all the things like serologic evaluations and other kind of cultures are have their own limitations. I think the one thing that maybe you could hang your hat as probably a true gold standard would be like a lung biopsy. And believe it or not, there's actually an art there actually is some literature behind this, and there's one published in Clinical Infectious Diseases in 2002 where they actually talked about doing this, and you use like a needle you insert into lung, and you aspirate, kind of like and I was never doing this, but kind of like we did back in the day, using getting cultures from otitis media samples. I think the tough part with that obviously is sticking a needle into a kid and all the reticence that people might have about that, and trying to get that by an IRB. If you read about it, it sounds like it's actually a pretty safe procedure with pretty minimal downsides. But again, I don't know that we'll ever get there. And then if again looking at the causes, so this these are like the kind of the published article. This is in New England Journal. So, birth, you have the group B strep and enteric bacteria, of course. And then as you get into that 4-month to 4-year age range, the predominant cause is going to be viral things like RSV, parainfluenza, flu, et cetera, all these other things. So just to keep that in mind. This actually, I don't know if many of you have seen these before. The first time it was showed to me, I was like, huh, it's interesting. I think I buy it, but I don't know that we really practice this way. So this is the IDSA guidelines that basically say that there's strong recommendation, there's high quality evidence and a strong recommendation that that antimicrobial therapy is not routinely required for preschool age children with community-acquired pneumonia, because viral pathogens are responsible for the great majority of disease. So this isn't even incorporated into our pathway. So as many of you know, we have pathways here. So this is our pathway for treatment of community-acquired pneumonia. And if you look down this way, mild pneumonia outpatient treatment, initial antibiotic recommendations, there's nothing in there about, like maybe don't even do antibiotics. The first line is going to be amoxicillin. There's nothing even in here about caveats with viral pathogens, et cetera. So it's interesting, right? And then I guess this obviously begs the question, do bacterial pneumonias actually happen in young preschool age children? And I mean, the answer is, of course it does, right? But how often does it happen? I think that's where it's a little bit hard to know. This was a kid that I saw in the past. I was a 4-year-old with fever for 4 days, had a resolving URI. And I think it was just, honestly, if I remember correctly, this exam was not impressive as far as like crackles and, anything that pointed to pneumonia. I don't even think we were thinking pneumonia, but because of persistent tachycardia, we did some labs and which showed a white count of like 20,000. We did a screening chest X-ray because of the white count, and here you can see this. I mean, when you look at this, it looks different, right, than that first chest X-ray. Right? I think many of us would agree this really does have the flavor of like a bacterial pneumonia. It seems like a low bar thing, elevated white count, fevers. It doesn't have that kind of look of that first case. And this was right as a right upper lobe pneumonia. So what we really need, I think, when we're talking about this is like, is there something that we can do that either with a combination of clinical lab, some kind of imaging, maybe that can actually tell us that the kid has pneumonia. And when we say pneumonia, we're probably really talking about bacterial pneumonia, right? And then who are the children really that might actually benefit from a course of antibiotics? And so I think there is a role for ultrasound. We'll talk about that in a little bit. Just first, we're going to talk about chest X-ray. So this was actually an interesting discussion I had with a radiologist here at CHOP. So we were doing a lung ultrasound study, and we're talking about gold standards and what should we use, and how about a chest X-ray? And then this radiologist said something to the effect of like, why would anyone get a chest X-ray for pneumonia? We all know it's basically crap. And I mean, you heard that. I was like, this is coming from a radiologist. And he's like, why do you think everyone orders chest X-rays? Like, I mean, and he was saying like, why do you get it? Because we know it's crap. And I mean, if you look at the literature, it really, I don't know, crap, but it's variable. Like the sensitivities are, all over the place. It can be fairly low. There's lots of studies that show that there's questionable even inter-rater reliability. So if you look at radiologist to radiologist, board certified radiologists compared to each other, there's questionable inter-rater reliability with kappas in like the 0.4 to 0.6 range, or even lower. And then there's even, it's not even recommended for routine use by the British Thoracic Society or IDSA. So, we do it, and I think it's ingrained into many of us throughout training. But there's definitely some question about it. So, what about CT? So CT probably is a better gold standard. But even this has its own faults, and of course the main limitations are, getting a CT is not so easy, right? And of course there's radiation risk, and then resource issues like getting the patient up to the floor, up to the CT scanner, which is usually often not in the ED. All right. So then what about lung ultrasound? So this was an interesting kid who it was a 5-year-old with fever and cough for 6 days, and had been on outpatient antibiotics. And so we did do a chest X-ray and to take a look and make sure there wasn't anything like a complicated pneumonia or something else going on. And if you look at it, there's this haziness on the left side, right? But you don't see it here on the lateral view. Like the spine looks relatively clean coming down. And so this was actually read by the radiologist as normal. So I always tell the residents, make sure you look at the x-rays too. I think it is important to look at it, because if you look at it, you're like, that doesn't quite look normal, right? And I think, I can't remember if this kid had crackles and made us more concerned, but for whatever reason, we did end up pursuing more. We did a lung ultrasound. And if you actually read the body of the report, it talks about it, right? That there's a hazy opacity in the left lower lobe, right? But not confirm the lateral view. So, but you could have easily seen, like, the resident comes and says, normal, right? And you do whatever. I don't know what we do next, like, searching for other causes of this fever. But we did do a lung ultrasound in this case. So here's the right lung. We're in the sagittal orientation posteriorly. It's a little quick, but I'll pause it in a second and kind of go through. But this is normal. You have the rib shadows. I think most of us here are probably, I don't need to go over too much detail, right? But these are the rib echogenic line with shadowing, and then this is the pleural line here below it, and then we have the A-line pattern, which looks normal. And there's the diaphragm down here, so no effusion, relatively normal. And then if you go to the left side here, you can clearly see already that that pleural line has what we call that shredded appearance. You can actually see into the lung now. So this is a sonographic consolidation in the right clinical setting, would be consistent with the pneumonia. So, and it was interesting, we actually showed the radiologist our study, and they did amend their read to say that given the ultrasound, they actually do think it is a pneumonia. And I think that was the right diagnosis. All right, so what are some of the pros and cons of lung ultrasound? So I do think it is more sensitive. Actually, there's not just me, but there is literature that shows that it's more sensitive than chest x-ray when you compare it to other things like CT scans and clinical findings, et cetera. The nice thing also is that there's no radiation, as we all know, can be done at the bedside, and can obviously pick up effusions, I think, better than chest x-ray. So sometimes you're confronted with like a lung whiteout on one side. Is that all pneumonia, which I've seen, and you do the lung ultrasound, there's no effusion, versus is it an effusion? And then you can also tell, is that effusion complicated, which has implications potentially for like doing a VATS procedure, et cetera. And it can be learned relatively quickly, and can also be used to follow lesions. So if we do it in the ED, it can be used to follow the kids on the floor. The cons, it may be too sensitive. We're going to talk a little bit about this, that I think this is the one where we have to be a little careful, I think, especially with some of the studies that I'll talk about in the next few slides, that maybe it is a little too sensitive and we're probably overcalling things a little bit. There's a question of can it miss deeper pneumonias? Although there is actually some literature that shows that this happens very infrequently, probably less than like 2 to 3% of the cases, and that most pneumonias actually are kind of pleural based, and certainly can miss other pathologies such as like tumors and rib fractures and cancer, mediastinal mass, foreign bodies, et cetera. So there may, again, still be some role for chest x-rays or and doing the lung ultrasound if your differential is a little bit broader than just looking for pneumonia. And in the same vein, it's harder to kind of get that global look. Obviously, with the chest x-ray, you get everything kind of all at once. All right, so these are just kind of some select studies. I think many of you are familiar with some of these. I'm just going to highlight these three for now. So this is a study by Copetti, 79 children with pneumonia, where they did lung ultrasound and chest x-ray. And the bottom line was, and this one was just that the lung ultrasound picked up more pneumonias, 60 patients, whereas the chest x-ray only had 53. And of the six, there were 6 patients that where the ultrasound was positive and the chest x-ray was negative. And the authors felt like that all 6 of those actually had true pneumonia, either confirmed by CT or by a clinical course that was consistent with pneumonia. So again, showing that it's could be more sensitive than chest X-ray for picking up pneumonias. These next 2 studies, I think by Jim Sung's group, I'm not sure if he's joined us today or not, but this first one was basically, the interesting is this one was that they did a prospective study looking at patients getting a chest x-ray, I think, as the gold standard, and doing lung ultrasound, and that they had a significant number of sonographers that were relatively novice sonographers, and their sensitivity and specificity were actually pretty decent, 86 and 97%. And then they did a kind of a subsequent study that looked at seeing if you could feasibly substitute lung ultrasound for chest x-ray. And so it was a randomized controlled trial where I think one group got the chest x-ray, one group just got lung ultrasound to start, and then plus or minus x-ray afterwards. And they showed that you were able to reduce chest x-ray use, which is obviously great. Reducing radiation risk, et cetera, always is good. But the interesting thing I think in this one is that they had a much higher antibiotic usage in the lung ultrasound arm. So I think the question again is, maybe are we so sensitive that we're maybe over treating a little bit in some of these, I think in this study, they even called like less than 1 centimeter consolidations pneumonias. This was a study by a group in Italy. So lung ultrasound for the diagnosis of pneumonia in children with acute bronchiolitis. So they took children with bronchiolitis who were getting a chest x-ray to rule out pneumonia. And they used a gold standard of basically an expert opinion where this expert clinician would look at everything, including the clinical presentation, lab, and chest x-ray to diagnose pneumonia. Again, not to belabor that point, but or not to go into the faults of that, but the interesting thing from this study, I think, is that when they talked about the size of the consolidation and defined it as greater than a centimeter, as opposed to including all consolidations, their specificity increased from like 84% to 98%. And this kind of gets back to the title of my talk, where maybe there's something about the size. So again, we don't know what that is. Is it 1 centimeter, 2 centimeters, 3 centimeters, 4? But there may be something with the size of the lesion that can help us better decide who actually has like a bacterial pneumonia or a pneumonia that needs to be treated with antibiotics. This is another study by a group out of Australia. It was a prospective observational study where they took kids getting a chest x-ray for pneumonia and used point of care ultrasound. And their sensitivity and specificity was pretty decent, 91%, 68% for pneumonia. But I think the interesting thing in this one was that of those who had sonographic consolidation, but didn't have it on x-ray or whatever, so they, or for whatever reason, didn't get antibiotics, almost a quarter of them actually improved without antibiotics. And a larger proportion of these were those consolidations that were smaller than a centimeter. So again, I think that maybe the size of the lesion actually does make a little bit of a difference. All right, and so what are we looking for a lung ultrasound? I'm not going to talk about too much of these. I do want to kind of propose some definitions, or as I talk about some of these definitions of like A lines, B lines, et cetera, and kind of my understanding of these. And I hope some of you will cut in and correct me or provide your input as well, because I think some of these are still a little bit unclear. We use them somewhat inconsistently. All right, so my understanding again of normal lung and A-line pattern. This one I think is not so controversial, but normal lung is an A-line pattern, right? So you see a nice bright pleural line with this reverberation artifact below, and this is a normal A-line pattern. So a normal A-line pattern is normal lung. It also can be seen, of course, in pneumothorax, or if you're just holding your breath. And then, of course, we want to see the lung diaphragm junction. I think this is to make sure that we don't see an effusion, also to make sure we're doing a complete lung scan, looking at the entire lung in that field of view. So in this one here is the pleural line, and here this is the diaphragm right here with the two. We call it the, I guess I use the term train track sign, but here's the diaphragm here with the liver underneath it. And the implication here when you see this interface is that there's no pleural effusion, at least in this view. All right. Moving on. So now we're talking about B lines, single versus confluent B lines. And so B lines have been described as discrete laser-like vertical hyperechoic reverberation artifacts originating from the pleural surface. And they extend to the bottom of the screen without fading. They obliterate A lines and they move with lung sliding, right? I don't know if anyone wants to contest that. I think that most of us are pretty comfortable with the definition. I guess one of the things I wonder about is like, what is the real definition between a confluent B line and a single? And does it really matter? I'm not sure it does, but I think when we talk about doing studies, it's important, right? Like, because clearly people distinguish them, confluent versus single B lines. People distinguish them, but again, what is the definition? And as best I can tell, and what I've heard is that people have said that confluent B lines are when they're more than like 50% of like an inner rib space. The problem I have with that is, of course, if you're looking in a transverse orientation or more oblique orientation, you don't have the rib spaces to deal with. So then what are we talking about? And then of course, the rib spaces can vary depending on the age and size of the patient, right? And everyone's a little bit different. So does anyone want to comment about what they think is the difference between a single versus a confluent B line? I don't know. I mean, I think it's one of those things that when you see it, you kind of know. It's like, it's hard to kind of describe. Like, this clearly looks like a confluent B line right here. This is all just hazy and washed out, right? This is definitely not a single B line. is this just an extension of that confluent beeline, or is this a single beeline? I don't know. I mean, you can maybe say that the edges look sharp on either side, but then, yeah, is there a size? Is it 2 millimeter or 3 millimeters? I don't know.
Hey, it's Erica.
Hey, Erica.
Thank you for this great talk. I can't say I've ever given that even 1 second of thought, because it's, as you say,
Yeah.
you look at it, you're like, oh yeah, that's a confluent
Okay.
beeline. But if I were to define it for research purposes,
Yeah.
that would be really tricky, because even, rib spaces vary in patients and their spacing varies. And I think we could probably make up our own definition of what a confluent beeline is, and everyone would be like, okay, because it doesn't exist, as far as I know.
Yeah. Yeah, and the point of this was because we were doing a project looking at lung ultrasound, so we were trying to define it. It was I had a heck of a hard time trying to figure out how to define it. And so yeah, I agree. I don't this may be something that we just have to do, like a consensus kind of Delphi thing, just to make something up. But yeah, if anyone knows, and email me if you ever find something that better describes it. And again, I don't know that it really makes a difference. Maybe we'll find they're the same, but again, from like a research protocol perspective, maybe there is some difference that we'll find in the future. There's different implications for the having single versus multiple or confluent. Yeah. All right, so I'm going to move on a little bit here to sonographic consolidation. And so as I understand it, a sonographic consolidation is when you're basically seeing into the lung. Is kind of this, I guess, the simplest way to explain it. There's an irregularity to the normally echogenic pleural line, which looks like there's a term called a shred sign or fractal sign that I believe was first coined by Daniel Lichtenstein, and he actually, so it's interesting if you look at it, a lot of the stuff that he publishes on that he calls, I think there's a difference between the shred sign and like what he calls it, I think, the lung sign or tissue-like sign. So basically, I think whenever you see the pleural line get shredded, and you don't see this one's a little arguable because it does look a little bit bright, but let's say that this was less echogenic, and you can now see into this, and you have this kind of edgy or shredded, like, I think he calls this like a fractal pattern. He calls this like more of a non-translobar consolidation, which to me implies maybe it's not as diffuse or as extensive as like a lobar consolidation, where like the entire lobe is affected. So he differentiates a little bit, I think, between a shred sign and where you basically just see like the lung like you just see the entire lung as tissue. Again, I don't know if any of us really distinguish that routinely, or again, I don't think I ever used to think of that. I'm starting to pay a little bit more attention to that. Again, and the thought is that maybe that the shred sign, these smaller, where you're just barely seeing into the lung, the pleural line gets shredded, you see this kind of edge, that maybe is kind of one of those indeterminate for pneumonia, as opposed to if you truly see a lobar, like kind of tissue-like consolidation, that's more concerning, or maybe a little bit more definitive for like a bacterial pneumonia. Again, I don't know. I think it's arguable. That's my theory, but again, it's something I just point out that as you guys pay more attention, maybe you'll have a better idea of this as well. And then I was always confused about this term subpleural consolidation. There's a recent article in 2019 by Daniel Lichtenstein, I think, where I'll send it to maybe Henry, that he can send it out to you guys as well if anyone's interested, but where he basically says that using the term subpleural consolidation is a little bit of an oxymoron, because by definition, a consolidation is subpleural if you see it. So I think that classically, when people said subpleural consolidation, they meant these small ditzels or small little things where you kind of see into the lung that imply like a viral pneumonia. But again, is this a subpleural consolidation, or does it have to be smaller? How big does it have to be called like a subpleural consolidation, where we're really implying that it's a viral process or a little bit of atelectasis or something where we're not as concerned? I don't know if anyone has any thoughts about that, but do people think that this term subpleural consolidation should be used, or do they use it to mean something different than just a regular sonographic consolidation?
Hey, Aaron, it's Jim Sung.
Oh, hey, Jim. Yeah, hey.
So I think part of the problem is we had, so the people who were first to do lung ultrasound were all Europeans, where the English was not really their primary language. And so, so I think that's part of the problem. And so I kind of agree. So like when we did that consensus conference for lung ultrasound, people all agreed, subplural, like by definition, all lung consolidations is subplural. So, so in a way, it was not helpful, but it just kind of, when Lichtenstein and Copetti first kind of published, that was the term they used. And if you've ever met them, you know that their English is, their spoken English is like not very good.
Sure, it's hard. Yeah.
The other thing about the shred sign, so my understanding from the shred sign from Lichtenstein is that it's actually the posterior border of the lung consolidation. So it's like when you're looking at that posterior border, it's actually the transition from consolidation. And then in theory, the reason why you're seeing that shred sign is there's aerated lung deep to it. And so that's why you're seeing it's actually the border of consolidation to aerated lung as you get deeper into the lung. And so that's what the shred sign is.
Oh, I got you. So what you're saying is that the shred sign implies not just that the pleural line here got shredded, but that there actually is a line deep where I don't know if you can see my mouse, but kind of like this.
Yeah, no, so that's what Lichtenstein refers to as a shred sign. It's actually the transition from consolidation, right? It's that posterior border where you're transitioning into aerated lung. So we're assuming that where you're seeing that bright shredded border, it's kind of like that's where the lung is aerated.
Got it. Okay. And is the implication that this is, what's the implication that this is,
no, so that like that's also another reliable sign that if you're seeing a consolidation and the posterior border of the consolidation is shredded, it's kind of like that you can think of as a lung consolidation equals bacterial pneumonia.
Interesting. All right. Yeah, I guess.
Oh, and then I guess your next point about like how do you measure them?
Yeah.
So so just in terms of a research, like what's clinically relevant, so the depth should be relevant, because if you think about an X-ray beam, right? It's like the X-ray beam is actually, it's going deep into the ultrasound. And so when we did our first lung ultrasound study, we actually noticed it's like the depth makes a difference whether or not the lung consolidation shows up on X-ray. So certainly, yeah, we actually found if the lung consolidation is more than 1.5 centimeters deep, that almost always would show up on X-ray. And certainly like all the lung consolidations that were less than 1 centimeter, it's like they did not.
Is it like, do you think that depth is more important than the width even?
Yeah, because it's like you can certainly have a wide lung consolidation that's like 2 or 3 centimeters, but it's only 1 centimeter deep, and that will not show up on a chest X-ray.
Chest X-ray, interesting.
Right. So and then the other, so like the truth about our first lung ultrasound paper was it was rejected by like 9 different journals before we finally got it published. No, and one of the reasons was we didn't do a good job of explaining why some of these lung consolidations were not showing up on chest X-ray. And then we had to, so like if you kind of read the discussion, we actually had to pull up the lung cancer data that showed that if your lung cancer is less than 1 centimeter, that's not going to show up on the chest X-ray, but it'll show up on a chest CT. And so once we put that in, then I think the reviewers like bought it. And then I think that's why we got accepted, because if we did not kind of like relate that to, you know, chest X-ray and like small lung cancers, the reviewers wouldn't have put 2 and 2 together.
Got it. So that's what I think where that 1 centimeter comes in is more. So if I'm understanding this correct, that 1 centimeter is more for the detection ability of chest X-ray rather than.
Yeah. So the 1.5, so I mean, in general, and actually we also did this stratified analysis, like when the lung consolidations were right about 1.5 centimeters, it's like all the radiology reads were like equivocal, they were like hedging. And then if it was like 2 or more, they were like definite consolidation. And then if it was like less than 1 centimeter, yeah, it's just like, it was just like not showing up on the chest X-ray.
Is that published? Because that kind of what I was trying to get at is that it does seem like I when I like just anecdotally when I tell people I was like if I do use like kind of 2 to 3 centimeter cutoff.
So in that 2012 Shaw paper, we actually have, it's kind of like it's a table where we actually stratified by lung consolidation size, and then so the axis is lung consolidation side on one side, and then how definite the chest X-ray reading was.
But that 2 to 3 centimeter number, has that been published anywhere?
So it's basically, I think we just made it binary. So like in terms of, it's either greater than 1.5
yeah,
or less than 1.5.
And so this is one of the things I was going to propose, like in some of these other studies, to maybe that, to stratify it by a little bit more. And again, it may not hold out. And obviously there's a spectrum, right? So I think it doesn't, just having like even a 10 centimeter consolidated doesn't necessarily mean you have bacterial pneumonia, but I do wonder if there may be some difference in, is it 1, 3, 5 or something? I don't know. And again, I think there's obviously going to be some variability with like where you measure this. Like, do you think people should measure it from like this pleural line to the deepest point or just to the closest point, right?
So I go the deepest, right?
Deepest, okay.
Because the thing is, right, so that shred thing is, it's kind of like an iceberg, floating, and you don't know how deep really the consolidation goes.
Okay.
Right, so I'll use the deepest, and it's almost always like reliable. So it's like if your maximum depth is like 1.5, definitely greater than 2 centimeters, it's like that'll show up on X-ray. And it's kind of, I've noticed that if it's not going deeper than 1 centimeter, it's kind of like that'll never show up on X-ray.
Okay. Right, good to know.
Jim, can I ask a question? It's Erica again. You said that the shred sign is indicative of bacterial pneumonia in particular, and I guess the thing I struggle with a lot is I often find these things on lung ultrasound. Pre-COVID, I used to I replaced all my chest X-rays with lung scans, and I have a really hard time distinguishing this bacterial versus viral sort of picture. Have you found any studies that allow us to distinguish bacterial versus viral based on sonographic appearance?
So we wrote a kind of a companion paper to our first, it's at 2013. Well, so like it was published in 2012, but then it was like, I guess in print in 2013. So the original kind of study was the JAMA PEDS one by Vishali Shah. And then when we did the study, we actually got hit with the H1N1 pandemic. And then so what I did was I took the fraction of patients within the first 8 weeks of like the 2009 H1N1 pandemic. And we actually, that's kind of when we noticed a bunch of things. Well, so it was actually an opportunity because during that time, the New York City Health Department had been doing viral surveillance. And they actually came out with the statistic that 90% of the circulating virus from like June, I'm forgetting, it was like May to June or something, was the novel 2009 H1N1. And then we're like, wow, we can, because it's like we weren't routinely getting viral data, right? And the only tests we had back in 2009 was it wasn't even PCR. I think it was like RSV antigen and the flu A B antigen tests, which have poor sensitivity, but like decent sensitivity. But the New York City Department of Health, they were actually doing PCR. So when they came out with 90%, well, we'll just kind of compare the background. Because it's like our definition of bacterial pneumonia was effectively, you needed lung consolidation with an air bronchogram. And then so by process of elimination, everything else was going to be viral. And so that turned out to be B lines, confluent B lines, and these very small lung consolidations. So I think we termed it subpleural consolidation because that was what the prior literature, like Copetti, called it a subpleural consolidation.
You didn't have any gold standard like bacterial diagnosis, right? You guys didn't. You guys didn't do lung biopsies, or like how did you know that it was bacterial? Like because they could obviously have flu and a bacterial on top of
Well,
it.
so one is they all met a clinical definition of pneumonia,
Okay,
right?
which
So
is probably the best. you
right,
can do.
fever, tachypnea, hypoxia, right?
But that
It's
could be the flu too.
I know, no, but I know. So, but the thing is, it's like, and so all we had was chest X-ray as the gold standard, and
Yeah.
so if they were
Which you know has limitations.
if they were calling lung consolidation on chest X-ray, right, and they've got fever, cough, tachypnea, it's kind of like there's no physician, no pediatric physician that would disagree that, well, if you've got a consolidation on a chest X-ray and the kid's like febrile coughing and tachypnic, right?
Yeah.
It's like the clinical diagnosis plus a chest X-ray with a consolidation. It's like, I think most reasonable people would say that's probably pneumonia and you're within your rights to treat that with antibiotics.
What we really need to do is people to start doing some lung biopsies. Anyone out there?
Well, no, so that actually is the gold standard. I mean, we were aware of that, but so the thing is, it just, at least the NYU IRB was like extremely conservative. Yeah, no, so actually we tried to make that initial study, I think, multi-center. And so I think it was Montefiore. Montefiore actually refused to approve the protocol. So we had already gotten it approved at NYU, and we were trying to see if we could get it approved at Montefiore. And they just said, we don't care if you're using ultrasound. It's kind of like, it's never been used this way in children. And they just like refused to approve it. Or at least they just kind of like sat on it and we're just like, well, we'll just run the study without them. No, so the thing is, it's like, I think that they called it what, transthoracic acid.
What did he say? It's non-trans lobar. It's like basically lobar versus non-lobar consolidation is kind of
so the thing is, like, now that we know that we can find these with ultrasound, like it's actually feasible. So like if we ever get into the situation where we have a super resistant, like killer Staph aureus, and you really need to get at the organism, I would just like keep that in the back of, that in the back of your mind. If like ID's like really pressing, we need to get the organism so we can figure out what the susceptibilities are. It's kind of like that'll be an avenue to actually get at the organism.
Jim and Aaron, can I ask you guys an additional question, just because this is such a fruitful discussion? So looking at these images here, if I had a patient with B, with shred and bronchograms that, had fever and some respiratory signs of distress, but maybe wasn't sick enough to admit, I'm pretty much treating this child with high dose amoxicillin, knowing there's a chance it could be a viral pneumonia, and then having a 24-hour follow-up. As opposed to if I had a patient that I saw something like E, potentially smaller earlier lesion, I may be inclined to not commit to antibiotics right away. But what I struggle with is, how do I know E won't be B in 12 hours? Like, what's the percentage of kids that when you're scanning in the ED have something that's like less, pronounced, that has the possibility of evolving to something that maybe from a consensus standpoint, everybody feels a little bit more confident that it's a pneumonia picture. And so I don't know your experiences, what you
So I think you're absolutely right. No, so like B is that, so that's the ultrasound. B is the ultrasound picture of what bacterial pneumonia is. And so if you've got fever, cough, right, and the kid, and maybe the kid's like 95%, so like not hypoxic enough to admit, that you're totally right to start antibiotics. And then if you're looking at E, we basically have enough experience now. It's kind of like, that's totally viral. It's like, you don't even need to think about starting antibiotics. Once you start getting around 1 centimeter, then so the thing is, it's like, so one of the issues is not all bacterial pneumonias need antibiotics. The problem is we don't have a way to tell, right? We don't have a way to tell which bacterial pneumonias need antibiotics or not. And actually, if you look at some of the literature from like low resource settings, it's like there was like a randomized controlled trial out of Pakistan, where it was like non-severe, WHO non-severe pneumonia in Pakistan. And then they randomized to like 5 days of amoxicillin versus like placebo. And it's like both groups actually did fine, right? The placebo group did just as fine as the
although I think with that one, Jim, right, is that the thought was that a lot of them probably viral pneumonias, right? That I think the age group was a younger age group.
Yeah, no, but so the thing is, it's usually when you're seeing panel C, they're actually falling right in that population, right? So then the question is, it's like, do you give antibiotics or not? So, if they've got more indicators, they're a little tachypnic, they might be pulling, but they're not completely sick enough that you want to admit them. Then it's a judgment call. Or if they're just having isolated fever, cough, and not respiratory things, and you see something like C. So like that, so in our 2016 paper, we made that recommendation. Well, we do watch and wait for otitis media. It's like, we can take that same strategy and use it for like these little ditzels of lung consolidations that we see that we know that won't show up on chest X-ray.
I guess the closest I would say, Antonio, was that one paper. This one is this Australian group. Again, it's small, right? The numbers are really small, so, and I don't know of any ones that actually had looked at that. And that may be a good study, right, Jim, of taking a look at, like, if you have like a sub-centimeter or sub 2 centimeter or sub 3 centimeter consolidation, and you didn't treat them with antibiotics, you'd have to figure out how you would do that or get that by an IRB, right? If you're calling it pneumonia or not, but
yeah,
but,
no.
but there was a significant number, like a quarter of these kids did fine without antibiotics, and I think they said something like, they were, at least they were able to follow them. You don't know if they went to other institutions or not, but they didn't bounce back to their institution.
So actually, the other thing that we've noticed over time, and I think this has to do with I think the pneumococcal conjugate vaccine PCV7 came out in 2007 or 2008. No, and then like 5 years later, it went up to PCV13. So what we've actually noticed over time is that so from our first study to the second study, the percentage of sub-centimeter consolidations actually went up. So I'm forgetting what the numbers are, but oh yeah, so I think about 20% of the total lung consolidations that we saw in the first study were less than 1 centimeter, like sub-centimeter. And then when we did the randomized control trial, a third of those consolidations were, so, and then the other thing is the prevalence of pneumonia actually decreased. And so we think that was the effect of pneumococcal conjugate vaccine from study to study. And so that was 2000, this study was done in 2013, published in 2016. And I think like more recently, so like it's going to be hard to study like bacterial pneumonia because I think we have good coverage of pneumococcal conjugate vaccine, that all the big whopping pneumonias are becoming less common. So certainly with the pandemic and everybody, all the kids masking and out of school, it's like, I haven't seen like a bacterial pneumonia, like there's been only a handful of times.
Although we're still giving out a lot of antibiotics, at least.
Well, no, but so the thing is, it's like
but I agree with you. Like we're probably not seeing as much like that kind of low bar.
Yeah, and then the other thing is, it's like we've liberalized our PCR viral testing, and so if we pick up a virus, and then the other thing is, it's like I'm doing the lung ultrasound, and if I don't even see, a lung consolidation that's more than 1 centimeter, like I'm not even giving antibiotics to these kids.
So you're using a centimeter. Are you using a centimeter cutoff, or do you think
I'm using
like
a 2-3 cutoff?
Centimeter. Okay. Yeah, I have to say, like I don't know, again, whether for right or wrong, and I'm not and this I really truly in putting this out to the group, because I don't know, I think we should probably try to study it more, because I even feel like some of these like 1.5 to 2 centimeter consolidations, I would feel like a lot of them really feel like viral pneumonias, to me at least.
No, I actually think you're right. So but the thing is, I think there's an evolution. One is, it's kind of like you need to be using lung ultrasound long enough to get comfortable with what you're seeing, and then you want to kind of like chart stalk these patients to see what happened to them.
Yeah.
So the good thing is, it's like I don't see them bouncing back, right? I don't see them going back to their pediatrician still sick, and the pediatrician like sees them a couple of days after you've seen them and like starts the antibiotic, unless they had something else like an otitis or a UTI. So like, yeah. So the good thing is, it's like I haven't gotten into trouble because it's like people said, it's like it's just early. Because like the concern with influenza is like, classically you get your influenza and then you'll have your bacterial pneumonia, a couple of days later, and like that really hasn't happened, right? So I think it's like usually when kids, and then our understanding of the respiratory biome is advancing. So we know that it's not just one organism necessarily that's like making the kids sick. It's kind of like, it's a combination of viruses and bacteria working together. And sometimes it's actually the viral infection that's probably driving the pathology. And so like, hence when you get into that asthmonia and bronchiolitis, right? Because it's like, there's all this literature that's showing that rhinovirus is actually a bad actor for bronchiolitis and asthma, right? It's like, if you've got rhinovirus plus an asthma exacerbation, some of the literature showing it's like that tends not to be responsive to steroids.
Yeah.
So
I will say that maybe at least we can agree that maybe to try to get away from this like subpleural consolidation term, just to simplify things, I think using the term sonographic consolidation makes sense. I think that there is going to be something with the size of the lesion. I did want to talk also a little bit about like these other findings. So we talk about air bronchograms, and like even I think I think one point, Jimmy, you had said like the difference between like a subpleural and a sub-centimeter consolidation is like the presence of air bronchograms, maybe. But it's again, it's how do you tell like what is an air bronchogram within this? Like, is this little dot an air bronchogram? Is that dot an air bronchogram? I think those are a little trickier, but I will say that there are, I think, more obvious cases. And also I'll point out this one. Again, I'm going to propose this one as an air bronchogram and what I call or I think it's not just what I call it. I've seen this in some articles where they call it a dot-like punctiform air bronchogram. So you see these little dots or bubbles of air. You know, I think this has, just looking at it, right? It's deep, it's wide, it's you know, it's big. It looks lobar. It looks like a pneumonia. You know, again, there may be something that's different between that and what I call linear air bronchograms. This is an article published by Lichtenstein in 2009, and you can see that. I mean, even here you see dot-like air bronchograms, and here you see linear. Again, why do you have the difference of those? I'm not really sure. I would say, you know, if just pay attention to these to see if, you know, if you're in your clinical experience.
Yeah, no, so you're absolutely right. So basically that's just the bronchioles going through the lung consolidation. So they remain aerated. And so if it's a dot, you're looking at the bronchiole and transverse. Whereas if you're seeing that linear thing, you're actually scanning the bronchiole kind of in parallel, or right, you're scanning the entire length of the either the medium airway or the terminal bronchiole, like en face. So you're seeing the whole length of this.
So you think it's just the orientation?
Yeah.
Oh, interesting. Okay. I don't think I've ever thought of it, because like you would think that there would be at least some linear, but that's interesting. I never thought of it that way.
So the other thing is it also depends on which machine you're using.
Mm-hmm.
So so the machines that I've always used, the Sonosite, they didn't really have that great, like we're going up to maybe 10 to 13 megahertz, but I think you had a TE7. So that can go up to like 13 to 15, depending on like how you're sitting, your linear. Mm-hmm. So if you have a high quality machine, you're going to get better resolution on the air bronchograms, right? Because you're actually looking at the terminal bronchioles and the consolidation.
Interesting. So this one, this is an example of I think a dynamic air bronchogram. So this, if you look, I'll play the video here. So you can see like these dot-like, but there is also some linear. And if you look right here, do you see the air kind of, that lung is moving obviously, which makes it a little bit challenging, but I'll play it one more time. But do you see how right here, you see this air kind of shimmering back and forth? My understanding of this is that when you see a dynamic air bronchogram, that implies that there's air obviously moving within the bronchi and within consolidated lung, and that helps to rule out atelectasis, so that this may be a little bit more definitive for pneumonia. I'm not sure if many of you have seen this before, or if you would agree or disagree. I think this has the appearance, again, I don't know that you really need that, but this clearly looks wide, deep. There's clearly air bronchograms. It looks like a lobar consolidation. And then just moving on to, like, I won't belabor fusions too much, but I think whether an infusion simple versus complex, we just had a POCUS conference where we kind of talked a little about this and how we probably don't send enough kids to VATS that we should, and partly it's probably because we don't see a lot of bacterial pneumonias anymore, as Jim mentioned. But I do think that if you do see something that looks like this, you know, where this is again the diaphragm right here, this is all very complex hyperechoic septated effusion within this kind of atelectatic versus consolidated lung right here, that this is a kid that, especially with the clinical picture, someone that's in more distress, this is a kid that probably would benefit from like a VATS procedure where they really kind of go in and really get rid of all that loculations and exudative effusion more quickly, that they're probably more likely to improve more quickly and get out of the hospital more quickly. All right, and then just to move on a little bit about, so there's many of you probably know about the Blue protocol that again is more for like the adult ICU patients. I was the first kind of I think the description of using lung ultrasound in a protocolized fashion to help figure out kind of the cause for hypoxia, respiratory distress. You know, and I think this Jim can talk about this, but this is a kind of a modified Blue protocol. I think there's, you know, I hopefully point out there's probably some things with like size and kind of maybe the types of air bronchograms that maybe we could refine this a little bit to help kind of differentiate viral versus bacterial pneumonia. Again, I think just taking a closer look at all at these scans that you're doing, I still think we need a little more work. I would maybe propose that you know, things that are small, again, whether we're using 1, 2, or 3 centimeters, probably are the majority of them are probably going to be viral pneumonias. What we're really looking for are going to be these larger consolidations, things with like linear or punctiform air bronchograms. And then I'm just going to close. I know we're running a little late on time, sorry, but is just with a few cases. This was a kid who had basically mycoplasma, SJS, where you can see here there's something on the left lower lobe, had again, right here, you see this small subpleural consolidation. You see B lines, again, single versus confluent. Hard to say. It looks like there's probably at least single. This is probably a confluent just by looking at it. Looks like there's something here. And then here, when we're looking at it in more of a kind of oblique, you can see it's definitely wide. It probably does go a little bit deeper. Again, but again, is there something with this pattern that we can maybe help figure out that this is mycoplasma versus another, like maybe strep pneumonia or lobar pneumonia? I don't know. This kid also incidentally had like something actually hiding in the right lung, which you don't really see very well here on the chest X-ray. But this is the right posterior view, and you can see here right at the very end, you see this sonographic consolidation right there. This one I wanted to point out because what do most people call these little things here? These little ditzels. Pause it really quickly here. So these things right here, that's this little thing right here, they're clearly not B lines, right? Because they're pleural based, but they don't extend all the way down.
Aren't they called Z lines or something? Not like bigger than comet tails,
right.
Smaller than a B line, not an A line. I thought Z line was the term we used for those.
Perfect.
Maybe
yeah.
not.
So that was what I thought as well. But if you look at the actual like definition that was proposed, like if you just like Google Z line, they say that that they don't move with lung movement, but these clearly do. Right. You see right there. That's like. So I don't know. I don't know if this is like a. And then we usually say, right, the Z lines can be normal, right? Like but I don't know. This is a kid with I would say pretty classic bronchiolitis. Again, is this really more of a Is this really more of I guess a really really small consolidation? It kind of looks like it. And again, I this whether we use the term Z line or something, I think there is something here, right? If you see a ton of these that just really look like a viral process, right? Like a viral pneumonia, COVID potentially, or something else. I don't know. Like we clearly wouldn't call this normal, right?
Yeah, I would say the frequency is more than you would
more
see
than
for
you
normal.
expect.
Yeah.
Yeah. All right, and then this was just lastly, this was a kid who actually had COVID. Again, you can see there's some lung sliding, there's some B lines coming down. And then I think the right side was a little bit more impressive. You could see more diffuse B lines, confluent B lines, pleural nodularity, and then it looks like this maybe, I guess what we would call that that shred sign, where you can see right here the lung is consolidated, and that you can see that kind of posterior border that Jim was talking about. And this was a patient that had COVID. You're using the linear probe, so you get a little bit better definition. Same thing on the left side, and on the right side again, confluent B lines. And then here you can see that kind of that shred sign and then it's interesting, right? This looks a little different than the other shred signs where it looks a little bit more horizontal, I would say. I don't know.
Yeah, I found when I see confluent B-lines, that's when I rotate the probe 90 degrees, and almost, not always, but often there's a more shred pattern hiding like right adjacent.
Adjacent to it.
What's happened?
You're talking about it specifically with COVID?
No, in general, not
Just in general,
specific
okay.
to COVID. I think if I'm seeing a pattern like this where it's
Yeah.
B-lines throughout the pleura, that's where I'm holding my hand still and rotating 90 degrees. And then oftentimes there's more of a little shred, but they tend to be small. So it's still, I'm still struggle with, you know, the right approach with all these cases.
Yeah, I guess I will say, like I usually say, it's like if you see B lines, do look in the oblique orientation, because every once in a while you'll find something that's even, I mean, sometimes they're small, but I would say sometimes you find something that's actually pretty big. You just, because you're where your axis was, that you were just a little off. If you just slide to the side, you'll actually find it better in that oblique view. It kind of like around an abscess, right? You often see this, that the tissue just gets very echogenic, or kind of looks kind of like this on the lung ultrasound. So anyways, yeah, I guess I don't know that I have, I more wanted to kind of bring this as a discussion, because as much as we are, you know, I was a big believer in lung ultrasound, and I mean, I still am. I just would say that there probably needs to be a little bit of caution in how we're using it. So maybe maybe this is going to personal bias, that at this point in time, I think that it's maybe best to use that as an adjunct to chest X-ray. That maybe maybe in the minority opinion. I still think there's some work that needs to be done. Otherwise, I think we're probably going to be over treating a lot. And just as you know, as Jim mentioned, I think just the incidence of bacterial pneumonias are much lower. So just be a little careful with what you're calling. I think the size probably does make a difference. You know, again, whether that's 1, 2, 3 centimeters or more. I think you have to be a little careful and just kind of see for yourself as you're using it more, you know, what seems to make more sense as far as like what be more like a bacterial pneumonia. I think that when you see that kind of lobar consolidation, where you get the tissue-like appearance of the lung, where you see that punctate, you know, air bronchograms, or the linear air bronchograms, or for sure like the dynamic air bronchograms, those are probably like the more definitive, you know, for bacterial pneumonia, that maybe the ones that really need aggressive antibiotics or aggressive treatment. And then just, you know, as people are doing studies, I'm not sure how many people are doing lung ultrasound studies, just to think about these things. And then maybe is there a role for like doing another consensus statement. I did look at, Jim, I did look at that consensus paper. I think you're talking about from that with I think Volpicelli was the lead author. But that it was, I think, more geared toward adults, or maybe not, but it didn't specifically talk about a lot of these other things, these topics of like, you know, like maybe what's the difference between like a Z line and B line, single versus confluent B lines. And maybe this, you know, it doesn't mention anything about like size of lesions and how to measure, but maybe could we do a better job of doing that? So that's all I have.
It was great, Aaron.
Thank you. Sorry, we were in overtime, but yeah, thanks. And thanks, Jim, for coming to give your input about that. That's super helpful. Were there any chats to? No.
Thank you. Great talk. Thank you. Thank you. Great talk. Asmodiolitis by Stephanie early on.
Like I see it, yeah.
There's a lot of verbal discussion. Usually there's more peanut gallery action in the chat room, but I think people were just captivated by the interesting sort of analysis that you got no peanuts today.
Great. No worries.
That was great.
Okay, thanks.